Good afternoon. My name is Dr. Joan Reed, and I want to welcome you all to today's program, The Impact of COVID-19 on Kids. Thank you for joining us. This webinar is sponsored by the Harvard Medical School Office for Diversity, Inclusion, and Community Partnership. The mission of our office is to advance diversity and inclusion in health, biomedical behavior, and STEM fields in ways that build individual and institutional capacity to achieve excellence, foster innovation, and ensure equity in health policy, locally, nationally, and globally. Our efforts support the career development of junior faculty, trainees, and students, identify and train leaders in academic medicine and health policy, and provide programs that enhance and enrich the pipeline. Today's webinar is part of our Equity and Social Justice Initiative. Our equity and social justice events have 4 areas of focus: 1, history and context; 2, culture and environment; 3, health disparities; and 4, leadership skills and development. When I think about today's program that focuses on children and families, it is clearly dear to my heart as a pediatrician and a grandmother, and watching the impact of this on my grandchildren and how it relates to their education, homeschooling, concerns about safety, and concerns about the future. I'm really looking forward to today's panel. Today, we're joined by individuals who've been involved in our DICP programs. We're joined by an individual who will be graduating tomorrow from the program, 2 alums of the program, and a fellow who will be staying with us into next year. So thank you for being a part of today's program. It's good when you come home. Some housekeeping notes. Chat will not be available. However, questions and answers can be posted by using the Q&A button at the bottom of your screen. Mics will be muted, and this session will be recorded and posted on our DICP website. So it's now my pleasure to introduce our moderator for today, Dr. Alden Landry. He's an emergency medicine physician at Beth Israel Deaconess Medical Center and founder of Motivating Pathways, an assistant professor in emergency medicine at Harvard Medical School, and the assistant dean in our Office of Diversity, Inclusion, and Community Partnership. And with that, Dr. Landry.
Thank you, Dr. Reed, for the introduction, and thank you to the panelists today for joining us. I also want to say thank you to the audience for participating in this important discussion. And also thank you to the staff of the DICP who've been working diligently behind the scenes, Teresa Carter and Ying Wong, for helping to execute this today. It's been, as we've gone on with these discussions, you all have been really instrumental in helping us share our vision and communicate to large audiences. So on behalf of Dr. Reed and I, thank you for the work that you've done. We've been highlighting the impact of COVID-19 on various populations, be it healthcare workers, Black and Latino populations, our Native American communities, and others. Today, we will focus on a group that at quick glance hasn't been impacted as much by COVID-19, at least from a health standpoint. Most of the disease burden and the deaths have been in older populations, and many believed that children would be largely asymptomatic carriers of this disease. That said, we are hearing more about this multi-system inflammatory syndrome in children and other potential manifestations of the disease in pediatric populations. Unfortunately, we won't be talking about that during this seminar. However, we're going to focus on the other ways that children have been impacted by COVID-19. We will discuss the impacts on the social determinants of health, mental health, primary care, as well as the disruption of K through 12 education. Thank you for joining us for this discussion. Before we move forward, I would like to take a minute and pause and reflect on the events of the past few weeks that may not be related to COVID-19. We strive to have conversations regarding equity and social justice, but there have been a few recent events that must be acknowledged in order for us to be true to our mission in this space. That said, I ask that you take a minute to remember both Breonna Taylor and George Floyd, 2 individuals whose lives were cut short. Please take a minute now and reflect on their lives and their experiences. Thank you. I would like to review the format of our presentation, and then I would like to introduce our speakers. As Dr. Reed mentioned, next slide, we have 4 amazing panelists that are going to be joining us for this discussion. We will have a moderated session of conversation with the panelists, and then afterwards we're going to open up for Q&A. Please take advantage of that space to ask questions for the audience, and I will try and peruse the conversation that you all would like to engage in and incorporate those questions into our discussion. And then hopefully by the end we'll have achieved our goal of having a robust discussion about the impact of COVID-19 on kids. So I'd like to introduce our speakers in the order that they will present. First is Dr. Rhea Boyd. And she is a pediatrician who works clinically in Palo Alto Medical Foundation and teaches nationally on the leadership between structural racism, inequality, and health. Dr. Boyd has a decade of experience in advancing community-based advocacy. She is the director of the Equity and Justice for the California Children's Trust, an initiative to advance mental health and access to children and youth across California. She is also an alumna of the Commonwealth Fund, Harvard University Commonwealth Fund Policy. Next is going to be Dr. Frenny Polanco-Walters. Dr. Polanco is a 3rd-year clinical fellow in adolescent and young adult medicine at Boston Children's Hospital and is a fellow in the Commonwealth Fund Fellowship in Minority Health Policy at Harvard University. Next will be Dr. Jacques Ambrose. Dr. Ambrose is a pediatric and adolescent psychiatrist at the Massachusetts General Hospital and is graduating from the Commonwealth Fund Policy Fellowship at Harvard Medical School. And last will be Professor Paul Revel. He is the Francis Keppel Professor of Practice and Educational Policy and Administration at the Harvard Graduate School of Education. He is the former Secretary of Health Education for the Commonwealth of Massachusetts and the founding director of HGSE's Education Redesign Lab. With that, I would like to first turn to Dr. Boyd. And Dr. Boyd, we were having this discussion in our pre-meeting and also in some side conversations. And we were talking about the impact of the social determinants of health, the changes in social determinants of health for many students who are impacted by COVID-19. And so for many students, school was a source of food security for both breakfast and lunch. And without schools, many of these students have been impacted in ways that we weren't anticipating, and that they don't have access to this nutrition. Can you talk a little bit more about what's happening to students who are now suffering from this gap in their nutrition needs?
Absolutely. First, just thank you again for having me here, and to our other panelists today. I'm really excited for our discussion. So when we're thinking about, as you framed it, Alden, the social determinants of health and how it's affecting kids in COVID, I think we first have to kind of zoom out and think about the larger background in which COVID happened. So what we know is that children have the highest rates of poverty of any age demographic in our country. And so the economic toll of COVID is going to uniquely impact children because they already have high rates of poverty. Right now, we know 1 in 5 children live below the federal poverty line in the US. And then since COVID started, we've seen an enormous spike in unemployment. So nearly 40 million Americans have filed for unemployment over the last couple of months. And among those, low-income families have been the most affected. The estimate is that 40% of low-earning families lost a breadwinner since COVID began. And low earning is defined by a household income of less than $40,000. So when you think about who's being affected by the economic downturn, we know it's kids and families who are already low income. This is particularly true for African American families who overall have the lowest median wages of any racial group in the US and who have consistently had unemployment rates that are twice that of their white counterparts, which has existed basically since the Great Depression. It's particularly true for Latinx and Indigenous families who also tend to garner lower wages. And so as it relates to nutrition, the result of that is that since COVID, the rates of hunger and food insecurity are rising. So the nutritional safety net that typically served low-income children in the United States includes like the school lunch programs, school breakfast programs, and the child and adult care food programs, and they typically served about 35 million children every day. And the food that they provided made up about 2/3 of kids' daily nutritional needs. But with school closures and decreased access to childcare, kids have lost and families have lost this important food source. And so the risk for hunger is going up. There have been some moves made by the federal government, by states, and by localities to try to address this predictable increase in food needs among kids and families. Some of those include the USDA issuing federal waivers to allow schools, despite their closure, to safely still provide food for families. So families will be able to go to school under certain conditions, including physical distancing, and get their daily meals for kids and parents. Federal legislation during COVID has also extended SNAP benefits to existing enrollees and increased what their benefits are, so that for students who aren't able to get their food source at school, they could then use their SNAP benefit to go to a local food outlet to get their food needs met. Other states have made grab-and-go meal sites available, so you can take food from the school and take it home. Food banks have extended the ways that they allow the community to interact by having outdoor pickup facilities. So there are a number of ways that the food safety net has tried to respond to this need. But I think an important take home as we think about the economic downturn and how it affects kids is that it has particularly led to increased food needs for kids and families.
And just to point out, one of the things that's happening here in Boston is the extension of the Electronic Benefits Transfer, or EBT program, so that students who are enrolled in public schools in the city of Boston, I believe on average are going to receive, those families automatically receive an additional $25 per week, which would account for some of the coverage of the cost for the meals that those students would be missing. So Rhea, you mentioned this briefly about the impact of job insecurity and the number of people that have lost jobs. And that has other downstream effects on families in addition to nutrition, one of which is housing instability. Can you talk about this and maybe any other unrecognized impacts of COVID when it comes to the social determinants of health?
Absolutely. So one of the concerns about already having a population that has a disproportionate rate of kids being poor is that the economic downturn will also affect kids' housing security. So at baseline, before COVID, about 1 in 30 kids were homeless in the United States, and up to a quarter of kids didn't know where they were going to sleep the next night. That's housing insecurity. And so it's a lot of our kids, 1 out of every 4, who aren't sure in certain localities where they might sleep. And in the midst of a pandemic, that obviously is of great concern when you're trying to physically distance and when you may need to isolate certain members of your household to prevent the transmission of this infectious disease. And so we worry about housing insecurity because it might contribute to overcrowding. It might contribute to kids being housed in multi-generational settings where perhaps there are more people in the household than rooms to hold them, which could increase their risks of exposures and spread of potential COVID. We also worry about the baseline risks of housing insecurity on kids' physical health, their emotional health, their psychological health, and their relational health with their family. It is an incredibly stressful experience for kids to be housing insecure or to experience periods of homelessness. And so it has been another concern alongside the food concern that we should address it. Here in California, we've had more progressive measures like moratoriums on evictions to ensure that families who have lost their jobs or have lost income and can no longer provide their rent or mortgage have a break from making those payments while we still have shelter in place. But many localities and many states do not. Sometimes it's left up to individual landlords to make the decision as to whether or not rent could be delayed or mortgage payments could be delayed. And so some of the advocacy efforts around housing insecurity have been to call for moratoriums or an end to rent payments, or at least a delay to rent or mortgage payments, or canceling those payments during this time.
You know, it's interesting when you talk about the housing instability is it's not just about hitting the pause button, but it's about making sure that those families do generate the income in order to be in a space where they can pay back for those delays in any sort of housing notes. It's working with banks, it's working with lenders. And so it really is taking this beyond just looking at whether or not the person holding the note is going to get paid, but making sure that all the other levels of this are addressed and that we go upstream. I just want to pivot from our discussion on social determinants of health into another space that we had a conversation about. And we were talking about how kids are coping with COVID. And you shared with me a story that I think would be really helpful for the rest of the audience to hear. Do you mind sharing what we were talking about when it comes to socialization and I guess more importantly, isolation that students or children may be facing?
Absolutely. So our other concerns are for kids' social and emotional well-being, and kids being isolated from their peers, outside their school settings, having their daily routines disrupted is incredibly unsettling for kids and can contribute to, as Jacques will walk us through, some pretty serious mental health concerns for kids. I shared a story that I heard on my local NPR where a mom basically described how hard it's been for her 5-year-old not to be able to leave the house, where she essentially said she was going to the post office and she let her know that she can't leave. And her 5-year-old said, you know, I don't care if I die, I just need to go outside. I think we worry about how kids' mental health is being affected by their isolation and the interruption of their exercise and all of the healthy routines that happen at school and outside. I think we also particularly worry about what it means for kids to also come to understand a world in which something like COVID exists. How does it shape their understanding of health or disease or of their risk for those things? I particularly think about this for African American, Latinx, and Indigenous kids who now have to consume media that consistently highlight the disparities in death rates and the reality that they may actually be affected or have had a family member or loved one or neighbor be affected or have died from COVID. You know, the estimates are that 1 in every 2,000 African Americans across our population have died from COVID. 1 in 2,000. When we think of all the kids that touches, I think we also worry about their own conceptions of their vitality, of their mortality, and how that will affect their mental health, their relationship to their peers and their family, and maybe even their relationship to their own racial identity or status. If we continue to talk about disparities in the media in a way that racializes them, or we blame certain ethnic or racial populations for the spread of the illness or for their own death rates, kids can internalize that and associate it, instead of with structural inequalities and racism, with their own racial identity. And that's really dangerous too. And it's a reason why a lot of us have been very careful and explicit in how we describe the racial disparities, so that that type of socialization isn't happening for kids.
Great, thank you. And we'll come back more to have this discussion with Dr. Ambrose, but thank you for sharing that story, Dr. Boyd. I next want to turn to Dr. Polanco. We've had similar discussions about access to primary care for children and its long-term ramifications, short and long-term ramifications. Can you talk about how primary care for children has been disrupted during this ongoing pandemic?
Hi, yes, of course, Dr. Landry. So even though children have not been affected as bad as adults in terms of morbidity and mortality related to this pandemic, as you alluded to earlier, the routine pediatric care they receive has greatly been affected. As a reminder, when we talk about primary care, we refer to care that includes disease prevention, health promotion, diagnosis and treatment of acute and chronic conditions as well. So one tool that we use to prevent disease are vaccines. As you know, vaccines are one of the greatest achievements in pediatric research. And while we do not yet have an approved vaccine for COVID, we're fortunate to have vaccines that protect our children from deadly illnesses. For the past few months, the rates of vaccine administration across the country has decreased. And as some of you may be aware, the Centers for Disease Control and Prevention recently published a study And they found that fewer childhood vaccines have been given during the COVID pandemic. So basically they compared two time periods of equal length, 2019 and 2020. And they found a decline in both vaccine orders and also in the number of doses that have been administered. This might indicate that our patients and their communities are at risk for outbreaks of vaccine-preventable diseases. And when I talk about vaccine-preventable diseases, I'm talking about measles, I'm talking about meningitis, and diseases and cancers caused by the human papillomavirus, or HPV, which is actually the most common sexually transmitted infection in the US. The same study showed that the decline is actually less prominent for children under 2 years of age. So that leads me to believe that some clinics are using different strategies to bring children in for their vaccines and are prioritizing younger children, understandably. But I'm an adolescent medicine doctor, and I also think about adolescent patients and young adults. So I urge clinicians to use some of these novel ways that they're using of providing care to also bring in the adolescents to their clinic. For example, I have been reading and listening in different NPR stories, reading in the newspapers, local newspaper here in Boston, about the wonderful ways that people have used novel strategies to get these patients to get this vaccine. So for example, some clinics have decided to hold vaccine drive-throughs. So basically you bring in the kids in the car, you go by the clinic, you don't have to go in, the staff member comes out, administer the vaccines, and then the family's on their way. Others whose primary care clinics are located in hospitals have decided to actually bring the vaccines to the patient in their own communities. And, it's true, not all the practices have the resources to implement such efforts, but it's really important to kind of think about what ways we can provide and prevent these vaccine-preventable conditions. In addition to vaccines, there have been delays in appropriate screenings and referrals. So as you know, well-child visits are great opportunities for screening for preventable and treatable conditions. For younger children, missing this visits means delays in assessment of their developmental milestones, while for adolescents, this means delays in reproductive healthcare needs and delays in screening for mental health problems, which I'm sure Dr. Ambrose is going to talk more about. Obviously, these delays can have potential harmful consequences if we don't attend to them. As an adolescent medicine provider, I'm concerned about the potential increased risk of unintended teenage pregnancy due to the lack of access to contraception during this period of time, and actually also lack of access to confidential care, as well as the lower rates of screening for depression, anxiety, and food insecurity, like Dr. Boy was talking about. So it is important to remember that if you're screening, you need to be prepared to intervene. So even if you're not having in-person visits, you can do this using virtual visits through telemedicine, but you need to be prepared to intervene. The other thing that I mentioned was confidential care. Some pediatricians share concerns, and some of my colleagues share the concerns about confidential visits, which we provide in person. Some of the strategies are asking the parent to step out of the room the same way we do it when they come into our in-person visits. And we usually don't have any problems when we ask the parents to step out. Most of them gladly do so because they understand that we want to protect their kids. You can also ask the patients to step outside of the house if possible, or use headphones, which a lot of my patients use. I also use yes and no questions if they don't have privacy. And ultimately, if they can have a visit that's confidential, I just ask them when it's a better time for me to do that. Some of the members of the Society for Adolescent Health and Medicine have been recommending a platform that is free, easy to use, and HIPAA compliant to reach marginalized population like those that Dr. Boy was talking about. So that's my long-winded answer to say yes, primary care has been disrupted significantly for all kids, newborns all the way to young adults. But there are strategies that we can do to make sure that we get their vaccines and we do the screening that helps them live healthy lives.
Thank you. And it certainly wasn't long-winded. I think there was a lot of useful nuggets that you included in there. I think one of the questions that ultimately we're going to have to think about is how do we, quote unquote, catch up for all of these mixed vaccines, missed opportunities, and these misdiagnoses, which is something I'm looking forward to maybe us talking about later on. One of the conversations we were also having is about the fear of getting infected with COVID and how this is limiting some people seeking out for healthcare. I notice it particularly as an emergency medicine physician with the decrease in the number of ED visits, but I'm sure this is happening both in the primary care setting as in the mental health setting as well. So how can we reassure parents that it's safe to bring their children into the clinic or to access telehealth or whatever it may be in order to make sure that those children are receiving the care that they need?
Well, clinicians, including pediatricians, because there's other clinicians who take care of kids, can inform the families about the strategies they're implementing in primary care offices to make sure it's safe to bring their children in for visits. We are also concerned about their safety and well-being. So for example, some offices are scheduling well visits in the morning and sick visits in the afternoon. That's actually exactly what my kids' primary care doctor is doing, which made me feel comfortable as a parent bringing in my kids, because even though I'm a pediatrician, I understand, I also have concern. Also, they're placing patients with sick visits in different areas of the primary care clinic from areas where the patients are receiving the well-child visits. Sometimes that's not feasible. So when the space is not available, it may be important to collaborate with providers in the community to identify separate locations for providing well visits for children. The American Academy of Pediatrics actually has provided guidance to us clinicians in terms of providing care for children and adolescents during the pandemic. They have recommended that all well-child care should occur in person and within the child's medical home to maintain continuity of care whenever possible. So they recommend that when telehealth is available, parts of the visits can be done virtually. As you know, when you go for a physical, we spend a lot of time discussing different things. And then the actual physical happens later in the visit. So they recommend maybe you can do the talk part, the conversation part virtually, and then having a timely follow-up in-person visit. Clinicians should also identify children and adolescents who have missed well-child visits and contact them to schedule appointments in person to catch them up as quickly as possible. So I think it's really important to tell the parents, we understand your concern, and it's definitely a concern that we have as well. And that's why all these things are being put into place to make sure. And we wouldn't bring our patients into in-person visits if we didn't think that it was safe for them to come.
Great. And one last question for you, Freddie. We've been talking about well-child visits, checkups, things along those lines, but unfortunately, some of the children that are impacted by COVID have really complex medical conditions. And so how has the management of these children with these complex issues changed?
Yeah, so we do take care of many patients with special healthcare needs, and that includes children with chronic conditions like asthma, disabilities, and those with medically complex conditions. So when possible, some of the services they receive have been provided virtually. And to be frankly honest, sometimes they haven't received the services at all. There have been a lot of schools closing and many businesses have closed during the pandemic. So this has affected the therapies and supports available for these children. So right now, the impact overall is probably unknown, but it may have significant and long-lasting consequences. So the way I see it is that we should encourage parents and caregivers to talk to their specialists, the therapist, or anyone else who cares for their child about any upcoming appointments. For many of these patients, delaying care can have serious complications, and clinicians can let them know if the appointment may be delayed or not. I have a lot of patients with complex special healthcare needs, and what we have done is that we have been in communication with them regularly during the pandemic to avoid having them to come to the clinic. However, like everything in medicine, as you know, we have to weigh risk and benefits. Many pediatricians and adolescent providers have successfully implemented telehealth to address some of this issue. I will share something though. The pandemic has uncovered the fact, at least for me, that telemedicine is not universally accessible. Not all my patients have access to internet. So when we started transitioning visits to telehealth in my clinic in Boston, I was happy because I thought, oh, we're going to reach all the patients. We have a lot of no-shows with some adolescent patients, and a lot of my patients just have transportation issues to get to the clinic. What I didn't think about was that not all my patients have access to internet with good enough bandwidth to hold a video call. Some families do not speak English and have low literacy. So accessing the video platforms we use is difficult, especially even when they have the added burden that they need to take care for someone with special care needs. So yesterday I spent 30 minutes talking to a patient, and it was mostly she moving from one corner of the house to another corner, and the call will continue falling through, and I have to call back. Ultimately, we decided to have the patient come for an inpatient visit next week, because I feel comfortable bringing her into my clinic, given the efforts that my hospital and my division have put in place to minimize exposure. And this patient has special care needs that need to be attended to promptly. Otherwise, there will be consequences that we may not be able to reverse.
Great, thank you. And it's interesting that you bring up this discussion around access to internet for telehealth, because I think later on I have a couple questions for Professor Revel about how that's impacted education. So it's not just only impacting telehealth, but it's also impacting education. So it's a good sort of nugget for us to think about as we move forward. Next, I want to turn to you, Dr. Ambrose. I have a few questions related to mental health issues that we're seeing and dealing with. Can you talk about some of the specific mental health challenges that children and their families may be facing due to COVID-19, both now and then also as Dr. Boyd was alluding to, some of the issues that families may be dealing with because of the pandemic and even beyond, with the number of deaths that families may be seeing?
Definitely. Hello, everyone. Thank you so much for having me for the panel conversation. I think, as a lot of my colleagues have mentioned, I think there are a lot of questions, and I want to be really mindful in providing answers, because, to be completely transparent, there's a lot of things that we don't currently know. I think one thing to kind of keep things into context is currently a lot of the focus is still being pinned on the infectious component of COVID. I think as we're seeing more states reopen and more businesses reopen, I think the non-infectious component of COVID, and many of which I think a lot of people have alluded to in mental health, will begin to kind of rear its ugly head. And I think looking at COVID, there are two components that I think might be helpful for us to examine, is the direct effects of COVID, and then some of the indirect effects of COVID on itself. So taking a look at the general population, I think some of the estimate thus far is for the general population, there's going to be a lot more mood disorders coming out, especially in anxiety. And I think taking a look at the population that have pre-existing mental disorders and substance use disorders, I think it's especially interesting because, like, this particular vulnerable group, their mental health services may very well be disrupted because the inpatient units are not actually natively equipped for some of the physical distancing that we require, nor have an overabundance of the protective equipment, or even the basic infection control tools like hand sanitizer, because some of those may be directly impacting their care of the mental health patients. Like, I certainly have taken care of a couple patients who would sneak around and drink the hand sanitizer. So I think these components create a unique challenge for the population that have the pre-existing mental disorders and substance use disorder. And then for those who are directly impacted by COVID, as in those who have survived the illness itself. So we don't currently have a lot of data from this population, but if we were to speculate from a similar pandemic with SARS, so we have some study coming from SARS showing that PTSD persisted for years in the predominant of those who have acquired SARS. And I think that the estimate was about 4 out of 5 patients in that cohort still reported PTSD symptoms years afterwards. And there are many things that we don't know about the potential post-infection neuropsychiatric sequelae, but I think they're very likely given the fact that it's a multi-system immune reaction. So there are a lot of gray zone, and I think that adds to the anxiety that people feel about what's going to happen afterward, because we don't really know. And I want to be really, really transparent about the things that I don't know just a lot. And then talking about the mental health impact itself, I want to raise attention to kind of like the elephant in the room, is this concept of the epidemic of loneliness. And I think this was initially coined by a former Surgeon General, Dr. Murphy. And I think the term social isolation is kind of a misnomer, because from a public health standpoint, we actually want people to physically distance. So now it's actually more important than ever for us to be socially unified. And I'll repeat that, because I think it's really important to recognize that while you are physically distancing, it is more important than ever for people to be socially connected. Because I think one of the things that we know very well from research is the chronic exposure to isolation have a lot of consequences on your mental health, both from a stress and traumatic component. But I think the other thing to kind of highlight is there are a lot of deaths that have already occurred based on the direct effect of COVID itself. And there hasn't not necessarily been a space for people to grieve. So I think the bereavement component has been really complicated. And I think looking at the intersection of minority families, I think there's some cultural component where people, I had a patient of South Asian descent whose grandfather's passing was really, really complicated, because traditionally there's a lot of community, there's a lot of gathering of people that allow for this solace to occur, for this communal grieving. And I think we're going to see more and more complicated bereavement coming out of this, because there is no community and there's no space. And then I kind of want to comment a little bit more on what Dr. Paloko-Walters and Dr. Boyle mentioned, is I think some of the indirect effects of COVID are really insidious, because we know that the insecurity in food, housing, and employment are steadily rising in the US. And we know that that's going to have a significant impact on the rate of anxiety, depression for a lot of folks, regardless of whatever population they had. And then for children specifically, I think like you mentioned, school closures have a lot of different meanings for kids. But I think I'll take them in a stepwise approach, but I think most concretely, school closure means there's less access to mental health services. And I think for a lot of children with special needs or who are on individualized education plan, that is absolutely devastating for their learning and their mental health. And the other component is that we forget that a lot of educators are actually mandatory reporters, and schools are one of those places where we can have another eye on the children itself. And I worry that the lack of mandatory reporters, we're going to have an adverse effect on the rates of neglect and abuse for children. And I worry that that may also increase as we see more data coming out from COVID. So also a long-winded answer.
Again, maybe long, but there's a lot to unpack there. I think it's, again, reflecting on my own experiences as a clinician, one of the things that we're seeing is longer and longer wait times in emergency departments for psychiatric placement because there aren't spaces available, the need for COVID screening for individuals before they can be placed in facilities. I also, you mentioned something about substance abuse disorders, which I'd love to try and unpack a little bit later. And then also the importance of mandatory reporters and teachers and coaches and other individuals who may be seeing children on a daily basis and recognizing those small changes. So I think there's a lot to unpack in what you said, and we can get to that in the questions later. But one thing that I wanted to ask about is what are some of the warning signs or red flags that the families can be doing or could be looking for in case there's issues that may be popping up in children and they just may not be recognizing it?
Yeah, no, I think that's a really good question. And I think since we're talking about really, really sensitive and important topic, I also want to say that it's super, super hot outside and I'm wearing a vest. So I apologize ahead for just like constantly wiping my face. But I think you asked a really good question, because I think this is a really unique time, because now you have parents and children in the same space, and they're kind of confined there. I have this little kind of nugget that I usually tell parents is like for their children, parents know best. So that the acronym that I use is BEST, like B-E-S-T. So because parents spend the most time with your kids, so you are the expert. Oftentimes when parents bring children to me, like I rely on them a lot of time, and I think parents are generally surprised because they expect like mental health clinicians to be like the expert to tell me what's wrong. But a lot of time I think of it as a partnership. I am there to help guide problem solving and problem diagnosis. So looking at the BEST. So B stands for behaviors. So oftentimes if you see that there are erratic, irregular, inconsistent behavior. So what I mean by that is a teenager wanting some alone time is completely developmentally normal. But if you live in the same house and you haven't seen your child outside of dinner time after like a week, I think those are definitely some warning signs and red flags that you should be aware of. E stands for excessive. So for younger kids, oftentimes we see that manifest in terms of mood disorder and irritability, because they don't necessarily have the vernacular to express the sentiment of anxiety, and it manifests as irritability. So you may see more of like this excessive crying and tantrum in younger kids that just does not seem to cease. So for BEST, S stands for safety. So really anything relating to wanting to die on a very atypical manner, or repeated mentionings of death in any fashion. So an example of this is I recently had a patient writing a letter saying that she'll miss her parents after she's gone. And the parent rightfully kind of alerted me to that because it was really atypical. And it was truly one of this very, very innocent way in which children let us know that something is wrong. And I think parents have a really, really intuitive sense in picking that out. And then the last letter is T, stand for time. How long has that behavior or that kind of action been going on? And really depending on the severity of the symptom, like if it's relating to the irregular and erratic behavior of your kids isolating, a day may be okay, but a week is not. And if it's severe, like safety, I'd say that definitely reach out to your provider. And like Dr. Polanco Walters mentioned, reaching out to your primary care provider as much as possible, I think this is one of those watershed moments in healthcare, I believe, that we have a really unique opportunity to break down the barriers in terms of mental health care, because this is one of those things that affect all of us. It's not something that one particular population only affects and no one else does. I think this is something that has ubiquitously affected everyone. So I think of this as a really, really important opportunity for us to destigmatize the way that we view mental illness, the way that we receive mental health care, and also the way for providers to deliver mental health care. And just to kind of give you the context of it, is like, this is like prior to COVID, is about 1/5 of Americans reported having mental illness in the past year. And I just think about like there's so many people on this conference call today, and 1 out of every 5 person have reported having some significant mental illness within the past year. And I hope that that level of impact can at least humanize the aspect of the mental suffering that people are experiencing. And I hope that it helped us connect to one another in a fashion that doesn't kind of stigmatize mental health as a moral failing, as a weakness of anyone, but rather it is just another disease that people experience. And the more that we can destigmatize it and break down the barrier, I think the better outcome we're going to have overall.
Great. Thank you. Thank you, Dr. Ambrose. Actually, I have one more question for you, but in the interest of time, I want to just transition and make sure we get to Professor Revel. And so, you know, it's been mentioned about education, schools, how valuable these spaces are for children for a number of aspects, whether it's the nutrition, whether it's the stability, the social interaction, or the mandatory reporting. Unfortunately, all of that's gone by the wayside for countless students across the country. And so, Professor, this level of disruption is unprecedented. Can you describe some of the immediate impacts that this is having on children and their families? And then also, what also is happening to some of the families as they're trying to care for children who are of school age in this K through 12 space?
Well, thank you, first of all, Dr. Landry, for inviting an education interloper into the discussion. I think this is just the kind of conversation that we need to be having between physicians and educators and others who care about children's well-being, which is so much more at risk now as a result of this crisis that we're in the midst of. So, I mean, I've likened what's happened in our field to an earthquake at some points that the field of education is experiencing something of the magnitude of an earthquake and is just getting up now and dusting itself off, connecting with other people, and beginning an emergency response to restore, basic services and basic sort of connections and communications that allow you to begin to bring together the resources to meet basic Maslowian needs and to start to rebuild systems, even if you want to pivot and grow those systems, develop those systems in new ways. So to bring that down to earth, it's a bit like a tidal wave following an earthquake that pulls back the ocean to reveal on the ocean floor deep, disturbing inequities that have always been there, but a lot of members of the general public haven't been aware of those inequities that surround schools and make it challenging for schools to do their job. I've been a believer for a long time that schools alone, as currently constituted, are just incapable. They don't have sufficient resources to deliver on the promise of no child left behind, on making every student successful. Suddenly, the general public is much more aware of the problems associated when children don't have adequate access to food, don't have adequate access to healthcare, to mental health services. Dr. Boyd was talking about and works in the area of social determinants of health. Well, we work in the area of social determinants of education success, education achievement and attainment. There are huge, important, influential social determinants there, which if we leave unattended, as we generally have, then schools alone are just inadequately equipped to deliver on the promise that policymakers have asked them to meet, which is to educate all of our children to high levels. So we're constantly hearing about school failure, but we hear very little about the condition in the lives of children that make it difficult for all children to come to school, let alone to be ready to learn. So let me get specific, and a number of these factors have already been mentioned, so I'll just touch on them. I mean, the first thing for children and families is children have lost access to basic supports, food, medical supports, adult oversight. The issue of mandated reporters and that kind of thing was mentioned. They've lost access to relationships, which is critical, with adults who are important in their lives and with their peers. The social and psychological dimensions, as again has been mentioned, particularly for special needs students with mental health issues, are enormous here and not being met in many instances outside of school. Connectivity, immediately when you send people home, you're sending people into vastly unequal kinds of environments. We have historical levels of disparity in wealth and income in our society now. And schools are an attempt to level that, a feeble attempt, but an attempt nonetheless. When you disappear the schools, then those inequities are right in the spotlight. And there's no way that this crisis will do anything other than magnify the gaps that exist between both opportunity and achievement for young people who are economically disadvantaged. So connectivity is an obvious one. And we'll talk more about that, I know, later, but just access to the internet, access to educational technology, access to the applications that you need, family support. So we've now said in education, unfortunately, we've done too little over the years to connect with families in a meaningful way. There's a lot of rhetoric about families being the primary educators of the children, and as Dr. Ambrose was saying, families know the children the best. Families are with the children throughout their childhood and youth, and yet we've not connected very well with families over time. Suddenly, families are at the center, and the families may not have the physical or financial resources, for example, to do the connectivity that I mentioned earlier, or to support students once they have the connectivity. Families' circumstances are widely different. We have some families that have both parents working, or only a single parent and a single parent working. We have other families where they have two parents at home all day and can juggle and support students in different ways. So I've argued for a long time that one size fits all doesn't work very well. This kind of factory model system of education where we confuse equality with equity doesn't work very well for students in school, but out of school and for families, it works even less well. Those are a few of the most immediate effects that I think have set people back. And what we're doing in the education sector is trying to respond as best we can to meet some of those needs. So again, as has been mentioned, I think there have been some extraordinary efforts in schools to prioritize caring over academics in this immediate aftermath of this earthquake, to do whatever they possibly can do to connect young people and families with food. We have food being delivered by teachers, being delivered by bus drivers. We have food centers being open 7 days a week in some of our schools, things of that nature. We've got efforts here in Boston. The Boston Public Schools bought upwards of 30,000 Chromebooks for distribution to students and identified dozens of hotspots around the city where people can connect. I know that school psychologists and social workers and guidance counselors, as well as principals and teachers, are reaching out to students and families to try and offer some semblance of support given the stress and uncertainty of these times. Teachers are trying to build new platforms and ways of educating young people under the circumstances. We've, in our education sector, been somewhat laggard in terms of the adoption of technology relative to medicine, for example, or relative to the private sector. And virtually, literally overnight, teachers have been asked to transform their curriculum to a curriculum that can be delivered remotely. And this has been a really tall order for a lot of teachers who had no background whatsoever. And they're doing the best they can, and they're juggling their own children at home, and they're trying to make sense and to learn new tools, just as educators and educational leaders in systems are trying to select the right tools and platforms and make sure kids get the equipment. So they're struggling. And I guess the bottom line, Alden, is that all of these things taken together sort of magnify the disparities from an equity standpoint that exist in terms of support and opportunity, as well as direct education. And as we look to the future, I'm somewhat hopeful. At one level, we've got public consciousness of inequity at a higher level than we've ever had before. So we have an opportunity to do something about it. If we fail to do something about it, my fear is that the gaps will grow. But if we take advantage of this rare opportunity of public consciousness, we may be able to move forward, close some of those gaps, and redesign a more equitable system for education in the future.
Great. Again, a lot to unpack in what you said. And one of the things that you were alluding to in your previous answer and some of the comments that we've heard from other members of the panel is the lack of access to high-speed internets and computers. And it's great to hear what Boston is doing. It's great to hear that some companies are providing free Wi-Fi and hotspots for locations for students to go to. I recently read some stat and heard this new term called virtual dropouts because students have not been engaging their classwork online because they didn't have access to internet or access to computers. And so can you just talk a little bit more about the disruption in learning that students are currently experiencing because of this lack of access to either technology or high-speed internet?
Well, I mean, the equity problem shows up right off the bat, just in terms of districts being able to reach out and connect with their students and know where their students are. In districts, we work with districts all across the country in my education redesign lab. And we're aware of some districts in which they're still struggling mightily to identify a very substantial percentage of their students who are just off the grid altogether. Nobody knows where they are. Teachers or principals don't know where they are and are not sure how to contact them. And here's where the social networking and the degree of involvement, you see extraordinary educators who have relationships with families, with community, with the students, and can track them down. So there are many sort of inspiring tales of teachers who've gone overboard and tracked down all the missing children. So that's step one. Then once you get everybody identified, you have to get them hooked up and connected. We had a superintendent in Stockton, California the other day, brand new superintendent out there, just started 4 days ago in the midst of all this. And he has 40,000 students in the school system. Only 4,000 of them are connected right now. So 36,000 students out of a total of 40,000 not connected 2.5 months into this crisis. So it gives you a sense of the magnitude once you connect them. Then once you connect them, you know, the issue is, okay, they've got the technology. Do we or don't we have internet? Now, internet used to be thought of not as an item that the public schools needed to worry about, whether kids and families had internet at home. Now it's become an absolute essential. And the question is, who takes care of that in terms of the budget? One of the struggles that school systems are both facing now and anticipating is what's going to happen to their budget. The federal government has not provided aid to state and local government. And so school districts are looking at what may well be extreme budget cuts in the coming fiscal year starting July 1st, at a time when the demands for services and capacity in those districts will be at an all-time high. One of the items, again, an example here in Boston that the Boston Public Schools wants to put into its budget is a guarantee that every family will be on the internet, because you can't learn without that. And just going to a center is a fine emergency response, but it's not a long-term way of learning. I mean, if we get people hooked up, we have the opportunity to break down the barriers of time and place that lock us into schools long-term. So this is a huge step forward if we can do it right. But right now we just have our emergency response. We're just doing the best we can because we had to do it overnight. But by next fall, we've got to have in place best practices. Other sectors, other schools, other kinds of schools have used technology more effectively than we've yet used it. We've got to figure out what those best practices are and give teachers training in how to do that. And then in the next juncture, connect with families so we can help give families the guidance they need to support their students working with these new tools and approaches. So there are lots of challenges within the field, but you can imagine the consequences. We talked about relationships and loneliness and the paramount importance of those, particularly when students return to school. That is just amplified and made more severe when students are cut off the internet altogether.
Great. You know, we're looking at technology and internet going from a luxury to a utility. And exactly. I think the way you're describing it is how we can not just do the I love the not just emergency preparedness, but what is going to be our long-term implications and how we develop solutions to these problems that COVID is exposing. You mentioned a little bit about that, and I want to build on that a little bit more as we think about what's going to happen this summer, how that translates into the fall, and what educators may be thinking about as far as summer preparation for students going into the fall with these disruptions, and then also some of the challenges that policymakers may be experiencing, thinking about summer learning in preparation for the fall. So can you talk a little bit more about what fall 2020 is going to look like for educators?
Sure. And I'm going to use a medical metaphor in my response here in a couple of ways. One, to your earlier comment, the emergency response and then the long-term response is a bit like, stabilizing a patient in a trauma situation, you've got to stabilize that patient before you talk to the patient about changing lifestyle and what they're going to do differently. And I think one of the things that we're going to immediately have to do, and I hope, is a sort of a paradigm shift in our field where we begin to, instead of batch process, mass produce education in a factory model kind of system, we're going to have to individualize, customize, meet children where they are and give them what they need. Each child needs to be seen, understood, and connected with by at least one significant adult. And this shift to individualization is more like, I often say what it means is, what we don't do in medicine is open a hospital and give everybody the same treatment and the same length of stay in a misguided sense that would be the fair way to deliver healthcare. We shouldn't be doing that in education, but it's essentially what we do. So we've got to shift to an individualization approach. We're going to have to take families much more seriously, communicate with them more, provide them with the wherewithal and support that they need to be strong agents in the education of their children. And that begins with assuring that kind of connectivity that we've already talked a little bit about. So we've got a revolution in individualization, in technology, in family engagement. And then finally, I think the other thing that we're going to have to put in place in our communities is something that we call children's cabinets, and we've installed in the cities that we work around the country, but where we come together and all the different organizations, individuals, leaders in a community who care about the well-being of children, from medicine, from criminal justice, from housing, from nutrition, from mental health, around a common table to say, this is all one family, this is one child, this is multi-generational. How do we build a cradle to career pipeline where we have formal systems of early childhood education, K-12 and higher ed? We work on improving those formal systems, but we wrap that pipeline with systems of opportunity and support that make it possible for each and every child to come to school each and every day ready to learn. So I think that's, a big step in terms of where we need to go. And finally, that'll mean changes in the role of teachers. I think one of the things that has to happen this summer is school systems are going to bend over backwards to do everything they can to provide learning opportunities for young people in the summer because of so much missed time. I've thought for a long time summer should be an entitlement, not an accident of birth. So we know that people who get learning opportunities in the summer surge forward, those who don't fall back. Now's our chance to make that an entitlement. And at the same time, teachers are going to need opportunity to train, to work differently. My wife runs a program, and I chair the advisory board at Harvard Medical School called HMS Med Science. And in that program, we brought people into the medical school, and they had firsthand experience in emergency room simulations that had to do with learning biological systems. Well, they had to convert virtually overnight to delivering that in an online platform. And they were able to do that because of the extraordinary resources at their disposal. We need to do that in mainstream public education. That's going to take an enormous amount of time for teachers to build the capacity and to make informed decisions about the tools and approaches that they're going to take there. So there's lots of work that we need to do in order to get ready to roll out a much stronger, better, more equitable response in the fall.
Wonderful, thank you. And I know we're butting up against time, and we have just maybe time for one or two questions. I know Dr. Boyd has prior commitments that she's going to need to engage in. And so I just want to turn to some of the questions that I've seen in the audience, but then also a question that I have for Dr. Boyd before she goes. We're talking about all of these compounding effects, whether it's the social determinants of health coming together, employment loss, housing instability, food insecurity. And this sounds like a recipe for disaster for adverse childhood experiences. Anything that we can talk about doing that can potentially mitigate some of these problems that we are thinking about, and how this may have some really severe downstream effects for children?
Yes, thanks. I really appreciate what Professor Revel said about the opportunity. And I think also Dr. Ambrose touched on this, like the opportunity before us. I think what we're seeing is a failure of our systems when they work as they have traditionally worked and when they work as they're intended to work. Like before COVID, 1 in 5 children lived in poverty, and that was like a static statistic for decades. Before COVID, 1 in 6 children had food insecurity, up to 1 in 4 were housing insecure. Like these are pre-existing problems for kids that will only be compounded in the ways that, you know, our colleagues here have so expertly outlined by this pandemic, but that have long existed. And so I think the way to reframe it now when we think about how do we address what we know will be the long-term consequences is how are we talking about systems change, particularly within healthcare and within education and the child serving systems in a different way than we used to. I think we used to think incremental change or low-hanging fruit was the way to approach inequities, was the way to approach disparities. I think now we're saying, actually, something's fundamentally wrong with the way these systems were made, how they serve certain populations worse than other populations, and we have to get rid of that. I think suggestions that have already come up that I really loved were, again, when Professor Revel said, kids need universal access to the internet. And when you said, Dr. Landry, that means internet access is a utility. I think we similarly need to think about access to healthcare, not health insurance, but actual healthcare as a public good. Every human in America needs it as a function of just standing on this land, not as a function of your citizenship or your age or your insurance status or your job, but because you're here, you can go to the doctor when you need to. As we prepare for the reemergence or recirculation of COVID, likely coming in the fall and the winter, I also think it underscores the need to have universal access to healthcare for everybody, universal internet, if it fundamentally is changing how we access education, and hopefully in exploring what universal looks like to make sure it actually touches everybody, we'll also rebuild a system that's less structurally racist and less unequal than it is now.
Thank you. Thank you, Dr. Boyd. Fernie, just want to turn to you really quick for this question. How can physicians continue to engage the communities that they were typically working with prior to COVID-19? How can we make sure that we're doing our engagement or we're doing our educational outreach so that there's not this loss of relationships that have been established over time?
I think that similarly to what we're doing right now, this panel probably would have been happening in person. We need to use the innovative solutions that we have in our hand if like we were talking about, there's access to internet. I think, even for us that are somewhat in some way privileged, I heard that my audio was going in and out because my internet in the location that I am in, it's not the greatest. So I think that we have to make sure to understand what our priorities are. When I heard about that hospital renting an ambulance every single morning to go to the communities to make sure they provide vaccine, that is a place that values the community. That is a place that is thinking about the community as a partner. And that's one thing that we have to remember. Are we in places that the mission and their vision reflect that? And if we are, we need to remember that the community, the hospitals where we work in are in these communities that need us the most. And this is one of those times. This is one of those times when the communities need us the most. So let's use the telephone, let's use talking. And remember, social distancing, or, like Dr. Ambrose said, physical distancing is what we need to do. There's other ways that we can gather together and try to avoid I guess an idle time during this pandemic.
Great, thank you. Jacques, I want to turn to you for this question. What can we do to make sure that we are supporting children, and how can we make sure that we're communicating appropriately to children, both about COVID, about the need for physical and social distancing, as well as addressing their concerns and making sure that we're speaking to them in an appropriate level of understanding that they can take with them?
I think that's a really good question. I find that as kind of I'll speak from my own experience. I think as a man-child myself, in talking with kids, I find that talking with them in a way that engage their own sense of curiosity is really, really important. So one of the things I typically tell my patient is whenever things go wrong, to just think of yourself that, you know, you're in a movie and this is a plot twist. And you just need to move on and try to figure out how to take this plot twist and make it into your own ending. So to answer the question specifically about some of the positive aspect about this crisis is that I think one thing to note is kids are incredibly resilient. And I think parents now more so than ever are learning different ways, mostly because they have to, but are learning different ways to engage kids in a way that doesn't necessarily denigrate their own level of understanding, but kind of engage them in a way that allow the kids to offer their own curiosity. And I think of technology as a really powerful ally. And I think of a lot of the generation for adolescents nowadays, one of the fundamental ways in which they connect to one another is through social media, through technological platform, and in online gaming. And so where a lot of adults are learning how to socially connect during this physical distancing, kids are already doing it. And I think one of the things that I love, I really want to emphasize for parents and for family is it is not selfish to take care of yourself. It is self-full. And let me repeat that. It is not selfish to take care of your needs, to take care of the space and emotional valence that you require so that you can better take care of your family. It is self-full. And I think taking care of yourself is one component of taking care of your children that often gets neglected during these crises. And oftentimes I think of it as a way for parents to kind of look inward and see what are some of the mental health needs that I am currently facing. Because kids have a really good way of sniffing out. They may not necessarily know the specific words, but they understand that their parents are stressed and their parents are sometimes understandably scared. And I think it's important to model ways in which you can deal with that stress. I think kids can learn phenomenal ways to deal with their own stress if parents are able to model the way that when I am stressed, this is what I do to take care of myself. When I am really, really feeling alone and down, this is one of the ways in which I can take care of myself. And same thing with the precautions relating to COVID. I've seen a lot of families think of really creative ways to like paint their masses, decorate their masses, and make the activity actually a really enjoyable part of a family building unit. And I think those are potentially really innovative ways to turn this crisis into an opportunity.
Great, thank you for sharing some of those opportunities for engagement of younger folks in this tough times. Paul, I just have one question as we're about to wrap up. Just want to talk about how we in medicine can partner with educators and take advantage of this space where there is disruption, but use it to our advantage to make sure that we are improving outcomes for children, both in the health perspective, but also from an education perspective.
Well, it's a great question, and I thank you for it. I think we're stronger than we are alone as sectors, raising our voices in common cause to do something, not incrementally, as Dr. Boyd suggested, but significantly about changing the conditions which underlie the problems that we both see in both our systems, the problems you see in the healthcare system, and the challenges that we see in education system. It's going to be about coming out of our silos and taking collaborative, collective action. It's going to be about sort of pacing. There's a certain amount of loss here that has happened. And part of leadership is determining how much loss your community can take and absorb before it's willing to get its arms around significant changes in new directions. So we're going to have to be careful in terms of thinking about how to time this. But I go back to the Chinese word for crisis that contains both danger, and we know the dangers, but it contains opportunity. And I think there really is an opportunity here for us to lift our voices collectively in medicine and education, get right in front of policymakers who are making decisions about budget and about policy with respect to equity and dimensions ranging from healthcare to education to internet, to counseling services and support, and say, this is our moment. This is I've called it a Sputnik moment in education. The launch of the Sputnik by the Soviet Union signaled a major change in our field, like a Marshall Plan for the federal government to get involved. I think we've got a similar Sputnik moment in the world of child development and child well-being, and I hope we can take advantage of it.
Great, thank you. And I just want to say thank you to all of our panelists for sharing your thoughts. I know we're butting up against time. If you can just bring up the slides quickly. We do have a quick survey that we would like all of you to take. So if you can please click through that before you leave. Just a couple other points. It was asked, just want to remind everyone that the conversation will be recorded and it will be placed online. So we look forward to hearing for making sure that that opportunity is available for you to review for future use. There was a question or two about access to resources for students over the summer. We do know a lot of the programs that we are working with are going to be available virtually, including some of our summer programs. So please engage those programs that you were interested in doing for your children because they will be available in that space as well. Please continue to engage the Office for Diversity, Inclusion, and Community Partnership at Harvard Medical School. We're going to make sure that this conversation continues. If you have further questions or issues that you would like us to discuss in these spaces, please reach out to us through Twitter or through our website. And if you have any questions about the fellowship with a number of our panelists have participated in or are currently participating in, to learn more about the Commonwealth Fund Fellowship in Minority Health Policy here at Harvard University, please visit our website. We're happy to engage with you and talk to you about programs and opportunities for career advancement for physicians in this space as well. And with that, I want to say again, thank you to Ying, thank you to Teresa, thank you to Dr. Reed, and again, thank you to all of our panelists for joining us. And I want you to be safe over this COVID season and be sure to practice physical and social distancing. Take care.